So that brings us to the newly diagnosed, right? What are the triggers to initiate, treatment? It has been mentioned before, the CRAB, right? The hypercalcemia, renal anemia, and bones. Those are the ones that have the symptoms. But again, the myeloma defining event, as mentioned before. So these patients initially, we will label them as smoldering myeloma if they have a bone marrow biopsy of 60%, or the involved to uninvolved, or of 100 or above. These are patients, before we used to say these are smoldering, let's just watch them. But now these are true myeloma, and starting treatment even when they are asymptomatic is beneficial. That also incorporates the PET and MRI scan. That is actually part of initial testing. So not only the skeletal survey, but the PET MRI or CT scans can now be used as initial assessment. So if they have one or more involved lesions, 5 millimeters or above. So those are the patients that you would you will start treatment on.
Yeah. So when we see a patient that has newly diagnosed myeloma, we basically are assessing how well they'll be able to tolerate whatever induction therapy that we can administer. And we try to assess what's the best regimen at that point in time. Probably the first thing that comes into our mind is, is this person a transplant candidate, or is the person not a transplant candidate? And a lot of that has to do with their cardiovascular health. As long as they don't have any significant cardiac comorbidities or pulmonary comorbidities, or not on any oxygen, then most patients, if they're fit and they're able to do all their activities of daily living and some exercise, they're likely going to be a transplant candidate. We recently published some ASCO guidelines with kind of the premise that age is typically not a determinator of whether we're going to take patients to transplant. That said, I don't know what you do, Yvonne, but for us at UCSF, we typically, look for patients less than age 75. There's a rare patient that's age 75 to 80 that might actually, in fact, be fit enough to go to transplant. But for the majority of patients, they're less than age 75. And honestly, the majority of them are less than age 70. So some patients that are older and have comorbidities like neuropathy, we might want to avoid agents that cause neuropathy. Some patients that have, cardiac dysfunction or have congestive heart failure, we likely will go low on the steroids, less dexamethasone. They'll have less problem with arrhythmias and also with water gain. And in some patients that have renal failure, we often have to adjust the doses of the medication. Sometimes lenalidomide may not be our first choice, a lenalidomide containing regimen for somebody with renal insufficiency. And we may choose something like bortezomib, cyclophosphamide, and dexamethasone. You already very well described the molecular risk status. And I agree that the high-risk patients, we tend to be very aggressive with the treatment of the high-risk patients. But we really usually don't have those data back when we initiate somebody with therapy. If we do, in somebody that has high-risk disease, typically it's an immunomodulatory drug plus a proteasome inhibitor plus a steroid, at least a triplet for people that have higher risk disease. The stage in my mind doesn't matter so much in terms of what therapy that we're gonna do right out of the gate. But I do think we have to make a decision right out of the gate whether we're using a PI plus an IMiD, a PI plus cyclophosphamide, and then which PI? Are we going to use bortezomib or are we going to use carfilzomib? I'm curious, Yvonne, to see what your favorite regimen is for in the pre-transplant patients and in the non-transplant patients. For me, in the pre-transplant patients, I'm still kind of a fan of KRD, trying to do 4 cycles of KRD as a pre-transplant. And that's kind of been my go-to, and that's what I do. In the older population, the non-transplant eligible, I think almost everybody can get lenalidomide, bortezomib, and dexamethasone. But lately, I've actually been giving a monoclonal antibody. I've been more interested in giving daratumumab with lenalidomide and dexamethasone because I think it's extremely well tolerated. How about you, Yvonne?
So yeah, so we'll come back to the the timing of transplant, but for like the induction regimen, I'm still a fan of bortezomib, lenalidomide, dexamethasone, and of course, in high risk patients, maybe adding dara, bortezomib, dara to the triple regimen, and based on the on the Griffin trial.